A very good morning to all, and thanks Manju for the invite. I'm supposed to talk on merging the structure and function for confident clinical decisions. I think most of the points are already covered and made it easy for me. And as you all know, the two important features in glaucoma include the structural damage to the RNFL GCL and the functional loss in the field of vision. So now what is the relationship between the structural and the functional changes in glaucoma? Whether the structural changes occurs first or the functional changes occurs first and both are present simultaneously, or can we use the presence of either structural or functional changes alone to make a diagnosis and assess the progression? So this slide on glaucoma continuum shows that the structural loss often precedes the functional loss by years. Significant ganglion cell loss occurs before it's detected on standard automated perimetry. This slide also shows that in the early disease, the visual field has a ceiling and OCT is more sensitive in the early disease. However, in advanced cases, OCT has a floor effect and the visual field is more sensitive for the analysis of progression. Also, we can use the GCL analysis in the advanced disease. But in moderate to severe glaucoma, both the structural and functional changes will be there and it shows a linear relationship. This is Garvey-Heath sectorization, which shows the relationship between structural and the functional damage. When you have a superiotemporal damage of the optic disc and the RNFL, you will get an inferior arcuate defect. And when you have an inferotemporal damage, the field defect will be superior arcuate. So now the next question is, does the structural change always precedes the functional damage? As previous speakers already told, in pre-perimetric glaucoma, you can have structural damage without a functional damage. And also sometimes you can get the visual field defect without a structural damage, especially in media opacity, non-glaucomatous causes, and in small paracentral defects missed by the RNFL circle scan. However, in most of the cases, you may be able to get both the OCT and the perimetric changes. And also the progression rates are different for perimetry and OCT. So relying solely on one modality leads to a delayed diagnosis or misprogression, and merging them provides more complete and accurate picture. Now you have combined indices to make it easy for the physician. You have combined structure function printout and guided progression analysis. This is the structure function printout which is already explained. You have the visual field changes. You also have the OCT, RNFL, GCL changes, and you can include the fundus picture also in this, and everything will be given in the same printout. And in the center, you can see the structure function correlation. Here the OCT RNFL changes are flipped for the comparison. So here there is a superior arcuate defect and the red area is the inferior RNFL defect. This is the guided progression analysis printout of the Humphrey. You get a trend analysis and also you will get an event analysis which shows likely progression or the possible progression. This is guided progression analysis of the OCT RNFL and this one is the GCL. So now let us look at some case scenarios. The case one is a 65-year-old male with no significant risk factors. Presented for a routine eye checkup, and on examination fundus, the right eye was showing an inferior NRR thinning with corresponding RNFL defect, and the left eye is relatively okay. And we did an OCT which picked up that inferior RNFL thinning, and also the GCL is showing the inferior loss in the right eye, and the superior left eye shows a superior small RNFL defect and also an early GCL loss. When we did the fields, it shows a dense superior arcuate defect in the right eye and early defect in the left eye. So in this case, you have the structural changes and corresponding functional changes also. So there is no doubt in this. This is a definite glaucomatous damage. And whether this is the combined printout of the same patient, and whether you want to start treatment or not depends on the other factors, and I'm not going into the details of that. Case 2 is a 63-year-old female who again came for a routine evaluation. On fundus examination showed inferior notch with an inferior RNFL defect in the right eye, and the left eye was relatively normal. And you can clearly see the RNFL defect here. And however, the perimetry was relatively normal, but in the pattern deviation, there was some scattered defects, but the total deviation was completely normal, so we cannot rely much on this. The OCT picked up this defect. It shows the inferior RNFL defect, and also the GCL is showing the inferior loss. So in this case, you have a structural damage, but which is not picked up by the functional changes, that is perimetry is relatively normal. So again, this case you may need a frequent follow-up if the intraocular pressure is normal. Otherwise, you may need to start treatment because it can be a preperimetric glaucoma. Case 3 is a 56-year-old female who has a known case of primary angle closure post-PI with this suspect. This was the picture in December 2023, which is showing an inferior RNFL defect in the right eye, and the left eye is relatively normal. So on recent follow-up in July 2025, clinically the RNFL defect and the disc looks almost the same. And the field defect was normal in the initial visit also, and the latest visit also the field is almost okay, but there is a small defect which is seen in the paracentral area in the right eye. However, the OCT, RNFL and the GCL was showing that defect. When we took the guided progression analysis of the OCT RNFL, it is actually showing a possible progression. And in the GCL, it was normal in the initial 2 years back, and now it is showing an early damage. So there is a definite structural progression in this case. So we took a 10-2 and which took up the case, took up the changes. And so there is a definite progression, and you may need to think of stepping up your treatment. And the central corneal thickness is also less. This is my last case. This is again a case of primary angle closure disease post-PI in both eyes. And the right eye is relatively okay. The left eye is showing advanced damage. And this is the guided progression analysis of perimetry, which is in the trend, it is almost normal or stable in the right eye, but in the event analysis, it is showing a possible progression. The left eye has advanced damage, which is almost stable in the perimetry. However, OCT RNFL was showing an early progression. Even the GCL is showing a progression in the right eye. The left eye is almost stable. So here there is a progression in the right eye. So the left eye is advanced damage. You may have to think of stepping up your treatment. So to conclude, a structural defect that matches a functional defect is the strongest evidence of true glaucomatous damage. In preperimetric glaucoma, a definitive progressive structural loss is the disease even with a normal perimetry. In advanced disease, shift the primary monitoring to visual field progression and macular GCIPL analysis. Thank you.
Thank you, Dr. Manju, for that excellent talk.